We're going to go ahead and get started with September's School Mental Health Community Practice webinar. I'd like to thank everyone for your interest and participation, and to special thank you to the IDA Partnership and Mary Ola for your continued work and technical assistance with our ongoing webinar series. Today we have Karl Rosston, our statewide suicide prevention coordinator for the Department of Public Health and Human Services, presenting on suicide and the culture of suicide in Montana. And this presentation will focus on suicide specifically in Montana and cover some national as well as Montana data, demographics of a suicidal person, and also resources available. Karl, we're very grateful that you're able to take the time and provide this important webinar for us. Mariola does have all of us on mute, and Karl will be giving us a few minutes at the end, and Mariola and I will monitor questions, and you can go ahead and type those in the chat box. Thank you again, and Karl, go ahead.
Okay, can everybody hear me?
Yes, we can hear you.
Okay, great. Okay, so as Aaron mentioned, we're going to cover a little bit in the period that we have, just some of the national numbers, Montana numbers, some of the demographics, warning signs, and then briefly how to intervene. And then probably the most important piece is that at the end we want to go over some resources that are available to schools and communities around the state, all through our office. So let's begin. Let's start with talking a little bit about the issue of suicide in the United States. Unfortunately, the issue of suicide is getting worse in our country. Over the last 10 years, we've seen more than a 15% increase in the number of suicides in the United States. We now have, and 2011 is the most current national numbers that we have, but we have well over 39,000 suicides in the U.S. That's about 1 every 13 minutes. Now, a number that I want you to kind of pay attention to is the 12.7. The 12.7 is the national rate of suicide in the U.S. And why that is important is, especially when we're talking about Montana, where our sample size is much smaller, rate gives us a better indication of the severity of a problem than the actual numbers do. So just remember that 12.7. Suicide is now the 10th leading cause of death in the U.S., and we know from the research that females attempt suicide much more frequently than men, about 3 to 1. However, men complete at a much higher rate, at about 4 or 5 to 1. That is primarily because men tend toward more lethal means, primarily firearms. About 70 to 90% of all suicide attempts are by overdose. However, overdose is, for lack of a better term, the least successful means. Only about 2 to 11% of overdoses result in death. Whereas when we talk about firearms, firearms account for about 51% of all suicides in the U.S., by far the most common means. Now, the next two points are of significant concern, but also an opportunity for prevention. We know that about 45% of all people who die by suicide saw their primary care physician within a month of completing the suicide, and about 20% within 24 hours of their death. Now, of course, the concern here is that primary care is missing the warning signs. We know that 70 to 80% of the people who die by suicide gave warning signs, and we're missing them. On the optimistic side, this is also a great opportunity that if we increase awareness with our primary care, we have a much higher probability of catching many of these suicides before they occur. Among very young children, suicide is still considered pretty rare, but unfortunately is on the increase. When we're talking about young, we're talking 5 to 14-year-olds. 2011, we lost 287 kids, and you can see from the previous years, we're starting to see a steady increase of anywhere between 10 to 12 kids each year in this age group. We've seen more than a 60% jump in the last 30 years in the suicide rate among these very young kids. By far the fastest growing population for suicide is young people, which according to the CDC, they consider 15 to 24. Suicide is now the second leading cause of death for a young person in the United States. We are losing more than 4,800 kids and young adults each year to suicide. We're jumping anywhere between 150 to 200 each year. What we know from the research concerning youth suicide is most adolescent suicides occur in the home and most often right after school. In your typical classroom in the United States, you have 3 students who've made a suicide attempt in the last year. And this last bullet is an important one. Most adolescent suicides have to do with an interpersonal conflict where they're trying to bring about change in somebody else's behavior. To put it real simply, suicide is a relational issue, and it starts in adolescence, but it's a relational issue throughout the lifespan, whether it's a lack of relationships or conflictual relationships. Among the elderly, we know that they also have a high rate of suicide. We lose about 6,300 Americans over the age of 65 each year. Now, of interest is that, especially for Caucasians, as we get older, the suicide rate goes up until you hit about age 64. And then what we have found is that the suicide rate stabilizes significantly for females but continues to go up for men. And what we have found with that in the research is as elderly people start to deal with life crises such as change in social role, such as retirement, and health issues which become more prominent after the age of 60, 64, what we have found is that women have support systems, women have networks. Men tend to be isolated. For every interpersonal relationship a man has, a woman has 4. And so once again, speaking to the relational piece of suicide, if there's a strong support system for a person, the probability of suicide decreases. Now the upsetting news when we talk about Montana. We currently have the highest rate of suicide in the nation. We're tied with Wyoming for the 2011. Now, this isn't that big of a surprise because we've actually been in the top 5 in the nation for the last 40 years. As a matter of fact, if you go back to 1918 when the Office of Vital Statistics was created, we've been a top-tier state for suicide every year. So this is not new. For 2013, for our most recent numbers, and this is the state numbers, of course, we don't have national numbers to compare it to, but we had 231 suicides, which keeps us right at around the 23 per 100,000 rate. Once again, remember the U.S. rate of 12.7, so we are nearly double the national average. Now, when we start taking a look at what are some of the reasons why Montana is so high, well, it's not just Montana. If you take a look at this map, this is the top 10 states for suicide are in red. States with the lowest suicide are in yellow. You see a predominance of Rocky Mountain region from Alaska all the way down to Wyoming, Colorado, and New Mexico. When we take a look at some of the geographic factors and other issues that are relevant in the Rocky Mountain region, there are several. And that's important to note because we're not talking about a single factor, we're talking about multiple factors and how they combine to play out. So one of the major issues we have in the Rocky Mountain region is social isolation, which if you think about it plays into the relational piece. We are spread out. Montana has 6.7 people per square mile, whereas the national average is about 88.7. If you take a look, the federal government actually has a classification, and 40 of our 56 counties are classified by the federal government as being frontier counties, meaning we have fewer than 6 people per square mile. And we have 10 of our counties that actually have less than one person per square mile. So social isolation definitely plays a role in suicide. Another issue that we have when we take a look, especially in the northern states, specifically Alaska and partly in Montana, exposure to sunlight. We know that we get vitamin D from sunshine, and low levels of vitamin D has been correlated with depression. And so in some of the northern states where we don't get as many sunny days. Our exposure we have a high vitamin D deficiency in many of our people. But that's only one factor. Another factor that's probably even more prominent is access to lethal means, primarily firearms. We know that Montana is number 2 in the nation in the percentage of citizens who own a firearm at about 63%. That's the number 2 only behind Wyoming, which is at 65%. The national average is right around 37%. We know from the research that a household that has a firearm is about 20 times the risk of having a suicide. So this is merely a correlation between access to a lethal means and the high percentage of suicides. Another key factor has to do with substance abuse, primarily alcohol. Montana is number 1 in the nation in alcohol consumption per capita. We are number 2 in alcohol-related death, and we are near the top in DUIs, binge drinking, and underage drinking. The correlation that we know, nationally, at least a third of all people who die by suicide have alcohol in their system at the time of their death. The preliminary reports that we are obtaining from suicides in Montana indicate that that level, that percentage is closer to 40 to 45% in Montana. So we know that substance abuse and alcohol play a definite role. Another issue we have, it concerns altitude. We have seen a number of studies that have found a positive correlation between altitude and suicide. Some of them suggesting that it has to do with metabolic stress caused by long-term oxygen deprivation. Some have suggested that it has to do with the fact that people who live at higher altitudes are more isolated, have more guns, and drink more. Either way, we know that there is a positive correlation. We also have a correlation with our American Indian population because we have a number of reservations on our state, as do many of the Rocky Mountain region states. However, in a few minutes, I'll show you some numbers. And the important thing to realize, though, is that Montana is only has 6% of its population are Native American. Montana is about 91% Caucasian. However, the rate for our American Indian population is right around 26 per 100,000 compared to about 22 for Caucasians. Now, you take all those factors that we've just talked about, and probably the greatest factor that we have is stigma, which is predominant throughout the Rocky Mountain region, but especially in Montana. Specifically, stigma around mental health and mental illness. We still deal with a lot of people who do not feel that depression is a real disease, that it is a weakness, and that many times people feel they are burdened to their families if they are depressed. And that inhibits their ability to ask for help. And we have found that this is a major, major issue and major, major difference we have with other areas of the country. For instance, we know on the East Coast, there is a much, much higher acceptance with seeing a mental health professional or counselor. There's not nearly the stigma associated in states like New York and Massachusetts and New Jersey and District of Columbia. When people have an issue, you go talk to your counselor. We don't have that in Montana. And that combined with the other issues that we've talked about lead us to have such a high suicide rate. Over the last 2 years, when we start taking a look at gender, it pretty much follows with what we know nationally. About 78% of the suicides are by men in our state. Now, there is a typo here that I was going to correct, but it was too complicated to correct. There you go with I want you to reverse the numbers, the 411 and 38. You see that American Indians have the highest rate of suicide, but actually over the last 2 years there's only been 38 suicides, whereas with Caucasians and whites there's 22.3 is the rate, and we've had 411 suicides. So please reverse those numbers. But you can tell by looking at the numbers that one might consider that there isn't much of an issue with our American Indian population, but rate tells us something different. When we talk about means, you mentioned about 51% for national for concerning firearms. Montana, 63-64%, much, much higher. Even more alarming is in the last 2 years, and when we start taking a look at suicides by firearms among youth, 18 and under, 75% of youth suicides were by firearm. So it is a much bigger issue among our young people than it is with our general population. Even more disturbing is when we take a look at causes of death. Over the last 10 years, suicide has been the #2 cause of death for a 10-year-old in our state. And that is it's number 2 behind unintentional injury. And it's number 2 from age 10 all the way to 44. In 2013, we had 40 youth suicides, ages 15 to 24. That gives us a rate of about 22. This compares to a rate of about 10.5 nationally for the same age group. And last year alone, 68% of the youth suicides were by firearm. Remember, I just pointed out that over the last 2 years, it's been 75%, but each individual year, we are finding that the rate is higher among adolescents and young people than it is for the general population. We also have a significant issue with our veterans, specifically our male vets. Some of you, it's gotten a lot of public attention in the last couple of years, but we lose about 65 vets a day to suicide. I'm 66 a month, about 8 a day. Our rate is about 64 per 100,000, which, once again, if you compare it to the national rate of 12.7, significantly higher than the general population. Another interesting thing that we start to use, we start to track our YRBS data, the Youth Risk Behavior Survey, which most educators are very aware of. We do this every 2 years in our schools. And one of the measures on the YRBS is percentage of students who have attempted suicide in the past 12 months. In Montana for 2013, we had 8%, nearly 8% of all Montana high school students have made a suicide attempt in the last year. The highest percentage among 9th and 10th graders, females more than males, which we expect, and our Native American population has made the most attempts. When we start taking a look at trend data for the YRBS, you can see that this is 1999 through 2013. And you can see we've actually had a drop in our high school numbers since about 2001, 2003. We've seen a slight drop in the numbers for high school. But what's concerning is in the last 6 years among our Montana 7th and 8th graders, where we've seen from 6.1 to nearly 11 to over 12% of 7th and 8th graders have made a suicide attempt in the last year. Other populations that are at significant risk are American Indian high school students. You can see their numbers of peaking at almost 21% for American Indian high school students who attend school in an urban setting, nearly 21%. And the highest population is students attending alternative schools at over 21%. And many of these kids, as you probably know, have been identified with some behavioral issues or even mental health issues. We also start to take a look at numbers by age group. And this is an area where we also differ from the United States. Nationally, the highest age group is 45 to 54-year-olds. But in Montana, our highest rate of suicide is in our young people, 25 to 34, and continues to be very, very high up to age 44 and 45. So this really tells you, if you take a look at this number, we have significant risk throughout the lifespan. There isn't a place where we get to a safe place. Another issue where we don't pay nearly enough attention concerns survivors of suicide. And just for some clarification, when we talk about a survivor, we're not talking about someone who has made an attempt and lived. We're talking about family members or loved ones who've lost someone to suicide. We know that for every completed suicide, there are 6 survivors. So when we start taking a look at the influence that this has had in Montana, we have about 1,400 new survivors every year in the state of Montana. Times that by 20 or 30 years, and we have a lot of people in our state that have been directly influenced by suicide. Yet many of these folks, because of the strong stigma that exists, are not able to talk about the pain that they feel or their experience. This becomes a much bigger issue when we start taking a look at the fact that research has indicated that a survivor of suicide is 3 times the risk of completing suicide themselves. So we have a lot of people in our state who are living in pain, yet do not feel like they can talk about it or even go through the bereavement and grief process of the loss that they have experienced. Now, when we start talking about our counties, now this is 20 years worth of 20 years worth of data, mainly because many of our numbers are so low in our counties that we had to take 20 years to make sure they were statistically significant. And I would say that Sheridan County, up in the northeast corner of our state, is an example of this. One suicide up there can give them a much higher rate. But over the last 20 years, they have had the highest. One county that has significantly been up near the top has been Deer Lodge and Butte Silver Bow. You can see that southwest corner of the state has had significant issues with suicide. Butte especially, Butte has had at least 5 adolescent suicides since November 23rd. So they have really struggled, and of interest, all the suicides in Butte have been by firearm. But other than those 2 counties, which if you think about the factors that we've discussed, there are issues with alcohol, easy access to lethal means. There's socioeconomic issues, there's altitude, there's lack of access to resources, a number of issues. Other than those 2, though, what you'll notice about the other counties is they're all very large. They're large counties, and they're sparsely populated. I often use Sanders County as kind of an example. Sanders County is the size of the state of Delaware, yet only has about 12,000 people. Beaverhead County, which is one of the largest counties in the United States, has less than 10,000 people in the entire county. So isolation, ability to have critical or crisis stabilization or crisis response is inhibited because of the size of many of these counties. Now back to the correlation with mental health issues. 90% of those who complete suicide have a major mental illness. Most prominent are the mood disorders, primarily depression and bipolar disorder, anywhere around 50 to 65%. Second most common diagnosis is substance abuse. Many times substance abuse starts off in adolescence as a form of self-medicating and turns into what we call a co-occurring disorder, where they have both a mental health disorder and a substance abuse disorder. Now, there's a point here that I do want to make. This does not mean that if you have a mental health issue that you are going to be suicidal. On the contrary, only about 14% of those who have been diagnosed with a mental health disorder will ever go on to attempt suicide. It's just the ones that die by suicide. 90% have a major mental illness. Here's the good news. We're getting better at treating depression, and depression is now seen as one of the most treatable of all psychiatric disorders. There's research to suggest that as high as an 86% treatment success rate for depression. But here's the catch. It's not just throwing somebody on a pill. There's more to it than that. It's the combination of medication and counseling. The antidepressants can help with levels of serotonin, imipramine, dopamine, all of those in the brain. However, it's the therapy that teaches resiliency skills, coping skills, new ways of thinking. It's the combination of the 2 that have been found to be the most effective. Another important piece, especially for schools, is what we call the rebound effect. And the rebound effect talks about that people do not come out of depression quickly. It's not something that's cured overnight. Even the best medications take a minimal of 3 to 4 weeks before they start to work. Most of the time, more like 6 to 8 weeks. However, there's many times that people that are severely depressed, there's such an incredible amount of mental anguish and pain associated with it, they just want the pain to end. I often correlate it to like having an emotional migraine. They can't think about anything outside their pain. They can't think about how it's affecting anybody else. They can't think about any other part of it. It's an all-consuming feeling, and they just want the pain to end. And many times suicide becomes a viable solution to ending the pain. And one of the things that research has shown is that when someone finally decides that they truly cannot go on and that suicide is the only answer they have, their affect can dramatically improve quickly. And so if you ever see somebody who you want to use the term they snapped out of it, I would be concerned. It is a red flag. What we know from the research is that the greatest risk of suicide is not while somebody is in the depths of their depression, but it's in the first 90 days that the depression starts to lift. And where it affects schools is that if you've had a student who has been, even an adult, who has been in an inpatient facility, the highest risk of suicide is not while they're in the facility, but it's in the first 30 days after they've been discharged from the facility. And many times they've returned to the school or to their community, and that is many times when they are at the greatest risk. All right, so we want to move on a little bit and start talking about some of the warning signs. These are the things to look for. Now, when we talk about the warning signs, the big thing here is that we're talking about a change in character. The person doesn't usually act this way, and now they are. We use a mnemonic called Is Path Warm, and we'll start going through each of these just to kind of give you an idea what it may look like. So I is for ideation. The student or the person starts to talk about dying. They start talking about death. They start to write about death. They start to have a sudden interest in firearms when one didn't exist before, or stockpiling medications, those type of things. But there's a change in their behavior where they're starting to express thoughts of dying. S is for substance abuse. There's often an increase in their use of alcohol or other drugs, which is outside of their normal pattern of use. Purposelessness, no reason for living, no purpose in life. Two of the behaviors that you will often see associated with purposelessness is they start to give possessions away. They start to give away music, jewelry, clothes, money, because there's no need for it to have them anymore. Another thing that you will often notice, especially in adolescence, but it's noticeable in adolescence, is a decrease in personal hygiene. I will tell you that any time that you see a decrease in personal hygiene, a change in a person's hygiene, you are usually dealing with some type of mental health disorder that is starting to come out. And many times change in hygiene is the first way that we start to notice it. Anxiety, many times there's a sense of agitation, there's difficulty concentrating, and we start to notice a change in sleep behavior. Many times we think of someone who is severely depressed as that they sleep all the time, and although that may be true, often we will see just the opposite, and there's an agitated sleep. They have trouble falling asleep. They wake up many times during the night. They wake up early, and they're tired. If you ask them, they're dead tired. They want to sleep, but when they lay down, they just watch the ceiling. Okay? T is for trapped, feeling like there's no way out. Another word that you could put in there would be tunnel vision. It's hard for them to see outside their pain. It's all-consuming. Kind of goes back to the emotional migraine that I mentioned earlier. And they start to think that this is never going to get any better, that it's going to be this way forever. And this leads into hopelessness, where there's no future orientation, there's no goals. You'll even notice in some people a change in their voice tense. Everything is in the past tense. There is no future tense with their language. Withdrawal. This often comes from they start to isolate from their peers. They start to pull away from their families. They drop out of sports and other extracurricular activities, possibly even dropping out of school. They don't return phone calls from their friends. They just start to pull away from everybody and start to isolate. There's also can be a lot of feelings of anger and rage and almost a sense of revenge in some of their behaviors, like they're going to get back at people by killing themselves. And where this often comes from is that it's important to understand that a person who is suicidal very much lives in a very isolated world. They feel incredibly depressed. They don't think anybody cares about them. They feel alone and that nobody understands them. And for the most part, this is very private. They don't talk about it because there's a huge fear of being judged. But what happens is then when they deal or when they experience a crisis, even a minor crisis, a breakup in a relationship or any type of conflict, it's almost like the last straw. And a lot of times you'll see the sense of revenge come out, like I'll show them, or you'll hear a pattern of life's not fair. Why is everybody else so happy and I'm so miserable? R is for recklessness. Many times, especially in younger people, we see impulsive behavior. We see high-risk activities, maxing out a credit card because there's the view that they're not going to be around to have to pay it. You will have substance abuse, gambling, unprotected sex, or multiple sexual partners. Lots of reckless, high-risk behavior. And finally, the M, there's a mood change. There's a dramatic mood change, a flat affect, a depressed mood, acting out of character. And one of the things we talk about, kind of tying it back to the relational piece of this, is how do you know if someone is acting out of character unless you know what their character is in the first place? So I really encourage, especially teachers who probably have more contact with kids than most people do, most of the families do, is to take the time to have a relationship with the kids you work with, because that's when you're going to start to notice these changes. Now, if you notice the changes, if you notice the warning signs, do not hesitate to bring up the word suicide. There is a myth out there that if you bring it up, that you could give the person the idea. There's not 1 ounce of research to support that. On the contrary, asking somebody who you've noticed the signs, asking them if they're suicidal, gives them an opportunity to talk. It validates their pain. It also validates that they're not in it by themselves, that there's other people that could be there that could help them. It's a way of offering hope, and often will reduce impulsiveness in kids. So do not hesitate to ask somebody if they are suicidal if you notice the warning signs. Now that kind of brings me into the role of ambivalence, because this is an important concept when we talk about suicide. Very seldom have I ever noticed a person who I would say is 100% suicidal. Most people talk about a part of them that wants to die and a part of them that wants to live. And what's important to note, there's a myth out there that people who talk about suicide won't do it. That is a myth. What's important to understand is that the part of a person who makes suicidal statements is the part that wants to live, not the part that wants to die. Ambivalence is also a major reason why overdose does not work, because with overdose you get time, and you get time to change your mind, and you get time to have fight or flight to kick in. And I'll give you an example. Previous to this position, I was at Shodair Children's Hospital for many years, and I had an 18-year-old student who ingested about 180 Tylenol. And, she bought the pills, drove herself into a field, ingested all of them. Well, within about 10 or 15 minutes, at that moment she wanted to die, but within 10 or 15 minutes, she started having horrible abdominal cramping, and she panicked, and she called her mom. And we had to airlift her to the University of Utah, but she lived. And that's one of the major reasons why overdose doesn't work. And it's important for us as educators or community members that when we work with or know people that are at high risk, is to tap into the part of them, that ambivalent part of them that wants to live. In a majority of the people, it's there. If you have someone who is suicidal, you want to be able to determine what level of risk. And these are just some simple things just to kind of get an idea of how serious their intentions are. How specific is the plan? Is it that they're going to go jump off a bridge, or is it my parents leave for work at 7:30 in the morning, my dad keeps the key to the gun cabinet underneath his bed? The more specific the plan, the higher the risk. Have they written a suicide note? Have they gained access to a firearm and practiced loading and unloading it? Those are all types of things that indicate a greater degree of risk. Then there's lethality. What's the proposed method? Overdose compared to firearm. And then availability, and that's a big issue in Montana. When I work with families or communities that have had very young kids complete suicide with a firearm, you've got to ask the question, what is a 12 or 13-year-old doing with unsupervised access to a firearm? And then proximity. How close is help? In our larger communities, it's much closer than it is in our rural eastern counties. Here's a big one when we talk about level of risk, and that is intent. Intent often leads us to missing things because we only look at the behavior and not the intent behind the behavior. What did they think would happen as a result of their behavior? Let me give you an example to help clarify this. We had two young women who were admitted to Shodair the same night. One of them had ingested 40 Coricidin. One of them had ingested 5 Advil. And I often ask, which one was suicidal? Well, the girl that took the 40 Coricidin had no intent on dying. She was trying to get high. Coricidin taken in high doses causes hallucinogenic effects. She had no intention of killing herself. She was trying to get stoned. The girl that took the 5 Advil read the bottle. It said take 1 to 2 tablets. She thought 5 would do it. Now, when she talked to her parents and told her parents laughed at her. They thought she was trying to get attention. Luckily, she went and told a school counselor the next day who took it serious. But can you imagine what would have happened if the school counselor had minimized the behavior? I guarantee you the next attempt would have been more severe. So don't always just take a look at the behavior, but take a look at the intent behind the behavior. We mentioned this earlier, but rescue, at least 70% of the people who complete suicide gave warning signs. It is rare where, as I review suicides in our state, it has been very, very rare where there hasn't been some type of warning sign. People might not have recognized it, but it's there, and usually unfortunately it's after the fact that we become aware of it. All right, so just to kind of summarize some of the stuff, I want to go over risk factors and protective factors for suicide. A previous suicide attempt is the greatest behavioral indicator of risk. If someone has made a previous attempt, there is a higher probability that they will attempt it again. We mentioned earlier concerning the correlation with mental disorders, specifically mood disorders such as depression and bipolar, and co-occurring disorders where there is also a substance abuse disorder. We have also found that there is a strong genetic component or family history, many times with mental health issues such as depression or substance abuse, but even with suicide specifically, that many times a parent or other family member has had similar issues. Issues of hopelessness, impulsiveness, barriers to accessing mental health, relational loss. Chronic pain and physical illness is a big one. We see this most often in our elderly, but issues, people who are experiencing chronic pain and are not being adequately treated, there is a much higher incidence of suicide. Easy access to lethal means such as firearms, unwillingness to seek help because of stigma, influence of significant people. We've seen this most recently with the Robin Williams suicide, which was probably handled the best that I've seen it handled by the media. Anytime, you have to be very, very careful when reporting a suicide that you do not glamorize or glorify the suicide. And if you noted in most of the media reports on Robin Williams' suicide, there was a lot of discussion that he had severe mental health issues, that there was a constant battle with substance abuse. And then most of the time they'll go right into, these are the warning signs of someone who's at risk, and here are resources. So media plays an important role in how, whether it's an increase in risk. Cultural and religious beliefs, you will see that this is both a risk factor and a protective factor. Much of the time it depends on your individual beliefs about suicide. There are some cultures that still see suicide as an honorable or noble way of resolving conflict. There are others where that it's more condemned or frowned upon. So it really is based on your individual belief system. Local epidemics of suicide, it's called suicide contagion, and this is often happens more often with young people, and I think this is what's going on in Butte right now, where you have a lot of high-risk people, and you have one youth who broke the threshold, made an attempt or completed, and many times it leads to others who are in similar pain. It makes it easier for them to do it. Issues of isolation, being cut off from others, not having access to support. Now we talk about the protective factors, and these have been found that if many times we focus more on enhancing the protective factors than we do on limiting the risk factors, because we have found through the research that protective factors actually decrease attempts. So effective and appropriate clinical care, that is both in our medical, with our advancement in psychopharmacology, but also clinical work with therapists and counselors who are better able to provide the treatment and cognitive behavioral therapy to help people identify new ways of thinking and new coping skills. Easy access to a variety of clinical interventions. I think that's my ballpark, where we provide communities with resources, we provide training, increase awareness, anything we can to raise the overall level of awareness concerning the issue. Restricted access to highly lethal means, making sure that firearms are properly stored and locked up, making sure that people who empty out their medications when they're not being used, so that's less likely to stockpile medications. Family and community support is vital for all populations, but where we have really found it to be a protective factor is among American Indian youth and our gay, lesbian, bisexual, transgender population. Family support is one of the key factors associated with suicide attempt and suicide risk. Support from ongoing medical, mental health, and substance abuse care. Learn skills in problem solving and conflict resolution. And we're going to talk a little bit about one of the programs we have for that in a few minutes. And then you'll see the cultural and religious beliefs. This time, though, on a protective side, where it's against the religion or the culture to complete suicide or to take your own life, and that can serve as a protective factor. All right, so we want to talk a little bit, just briefly, about what to do if you see the warning signs and how to talk to somebody who's at risk. So first, there's a few do's and don'ts. You do want to voice concern. You do want to ask them if they're suicidal and have a plan. And one of the biggest do's is you need to make sure you tell other people. You do not want to be sworn to secrecy. You do not want to keep it a secret. This is such an important issue that even with our primary care, if a patient discloses to a doctor or a nurse that they are suicidal and have intent, it is not a HIPAA violation for a primary care to violate confidentiality. It is necessary for them to get other family members involved and other resources in the community. Other don'ts, you do not want to leave the person alone. You do not want to act shocked or challenge them or argue or debate with them about their severity. As far as asking the question, there's some simple things that we always want to keep in mind. You want to allow the person time to talk freely, give themselves plenty of time, do it in a private setting away from other people. Probably the most important piece is persistence. Remember that the person who is suicidal often feels that they are isolated, alone, nobody understands them, and their greatest fear is being judged. And many times you might ask the question and they might say no initially. Don't let it be the only time you ask the question. If you saw enough of the warning signs to ask it once, ask it twice. It's the second time that the person is going to have a better indication that you're someone who is not going to judge them and could help them. The direct approach is the best approach. Coming right out, it's often best to verbalize your observations. Tell them what you have noticed. I've noticed you've dropped out of sports. You're not hanging out with us anymore. It seems like you're really sad, and you seems like you've been getting rid of a lot of your stuff. Are you suicidal? Are you having thoughts of killing yourself? Remember, you can do no harm by asking this question. It's not going to hurt. That being said, it's still a hard question to ask, and the important thing is if you can't bring yourself to asking the question, make sure you find someone who can, whether it's a healthcare professional, law enforcement, whoever. How not to ask the question. Any of these are going to lead to bad results. You're not thinking of killing yourself, are you? Or you wouldn't do anything stupid like killing yourself. All of those statements pass judgment. And if you ask this, I guarantee you the answer is going to be no, and it's going to be no matter how many times you ask. How to offer hope after if they've said yes. You want to validate their pain. It doesn't mean you condone it or agree with it, but what they are experiencing is very real. And many times just saying, I'm so sorry you're suffering so much. I'm so sorry you're hurting so much. Do not offer or do not pass judgment. Offer hope. Many times you can say one of these things. I don't want you to hurt yourself. Let's go talk to somebody. You don't have to do this alone. I'm not going to leave you alone. I'm not going to keep it a secret. This is too important. I don't want you to hurt yourself. So just saying that often is the hope that many people are looking for. And the getting them help, take them directly to help. Take them to the closest emergency room. Take them to the mental health center, the primary care, call 911, call the Suicide Prevention Lifeline, and they will bring help to you. So these are all, it's key is for you to take them directly to help and get them and get other people involved, whether it's family members or community people. Don't keep it a secret. All right, so just to end, we want to go over some of the programs that are available in our state. No cost. One of them is called QPR. This stands for Question, Persuade, and Refer. This is an evidence-based practice that is appropriate for everybody. It's about a 1.5 to 2 hour training, and all you have to do is contact me, and I will set up a training for you. I do about 40 or 50 of these a year in every corner of the state. We have ASSIST, which stands for Applied Suicide Intervention Skills Training. This is more intensive. This is a 2-day training, great for healthcare, school counselors, law enforcement. Another one that is available throughout the state. Mental health first aid. This is a kind of a new program. It's evidence-based, and it's a community training. They have a youth version and an adult version. We provide this training to communities around the state. It's an 8-hour training that teaches the fundamentals of mental health, how to recognize the warning signs, how to intervene, and how to connect people to resources. Signs of Suicide, the SOS program. This is a school-based program that's available to middle and high schools. This not only trains staff, but also trains kids on how to recognize the signs in their peers and how to intervene. There's also screening tools that are available. There's a great deal of flexibility. Schools can use components, all of it, or components of the program, whatever their needs are. There's also this great resource, and this is free. This is free from SAMHSA or off our website, Preventing Suicide, a Toolkit for High Schools. This walks schools through what they need to do as far as policy, procedures, how to talk to parents, how to talk to students, if a memorial should be done or how it should be done if there is a suicide. It kind of gives you a blueprint for prevention. We also have toolkits for rural primary care providers. This is available on our website and helps doctors, nurses, and front office staff assess their patients for risk of suicide and how to intervene. We also have this one for parents, parents as partners. One of the disturbing facts that we know about youth suicide is that about 86% of parents who lost a child to suicide didn't even know their child was depressed. So this booklet is a quick 9-page and helps parents understand and know what to look for as far as depression and suicide risk in their kids. We also have this one, and this kind of goes back to one of the protective factors that we talked about in learned skills and problem solving. The good behavior game is an evidence-based practice that is used in 1st and 2nd grade and teaches kids throughout the course of a school year resiliency skills, how to cope, how to express emotion. The research behind this game has suggested that even 30 years later, as adults, these people have the skills and has shown to reduce crime, substance abuse, suicide, and has actually decreased symptoms of mental illness in many kids. This is a program that we are working with OPI on being able to bring more into the state. We've been able to train about 60 schools in this, and we'll continue to explore ways to make this accessible to all public schools in our state. Finally, we have the firearm safety program. We have gun locks that we provide to primary care, law enforcement, public health. And the important thing on why we really want to emphasize firearm safety, 90% of the people who attempt suicide and survive will not go on to die by suicide. If they use a firearm, they will. So if we can change or limit the means, the lethal means, we have a much higher rate of success in helping people. And finally, it's important to note that we have the Suicide Prevention Lifeline, the 800-273-TALK. This is a national lifeline, but if you call it from Montana, it goes to either Voices of Hope in Great Falls or the Help Center in Bozeman. And there's people 24/7 available. There's a vet option that connects people directly to the VA crisis line. And you also see at the bottom our website. We have a number of resources on this website, handouts, survivor handbooks, the programs for primary care, research articles on jail suicides, on American Indian suicides, a ton of stuff that I'm always updating and adding to it. So that's definitely a resource that I want to make sure you're aware of. Well, that concludes my portion of it. Please feel free to contact me. My number is on the handout that is available in the PDF form. If I can be a resource to you in any way, please do not hesitate to give me a call or contact me. Thank you very much for your time, and I guess we're open for any questions.
Karl, thank you so much for your presentation. so much information and also some great examples. I want to point out, I've seen some Montana data recently that has also shown trends not going in positive directions about students who have intellectual or physical disabilities are also a very high-risk group in the state. And just wanted to point that out. Karl, could you talk a little bit more about the definition of survivor and who fits into that group? So maybe if there was a suicide in a small community, who might be defined by survivor in that group?
That's a great question, Erin. As I mentioned before, a lot of times people think of survivor as someone who has attempted and did not die. But in the terms that we're using it, it's a person who has lost somebody to a suicide, usually a family member or a close one. And we know from the research that on average there's 6 survivors for every completed suicide. Now, this becomes a little bit different when we start talking about Montana, where we have small rural communities. And we especially talk about it when we talk about our Native American or American Indian population, because in a small community, that number of survivors might go up to 25, or could even be the entire community that would be considered a survivor of a suicide, especially in smaller, close-knit communities where everybody knows everybody else. There can be a drastic effect on everybody in the community and not just the immediate family.
Thank you. And did you say, is there a cost for the SOS program?
It's about a $400 kit, but I will provide it to any high school that wants to implement it.
Okay. I guess I don't have any further questions. Do others want to chat in a question?
Erin, this is Joanne.
Oh, yes.
Hi.
Hey, Joanne.
This was a wonderful presentation, Karl. I mean, this was wonderful. It would be such a great template for other states to take some of this information you had in the Montana specific slides and actually help them create this for their states so that they might be able to have dialogues around this kind of work. But you know, Karl, I wanted to just ask, has there ever been or do you know of any kind of initiative to maybe reach out to those, the individuals that might be identify themselves as survivors, to create any cadre of individuals that might help with sharing these messages? Is that something that has been considered or even is advisable?
Well, and actually one of the programs that started in the last legislative session is that we created a suicide mortality review team. And we're actually the first state in the country to have this, where we are reviewing every single suicide that occurs. I get coroner's reports. I actually became a coroner last December, but we review coroner's reports and health records and mental health records. And one of the things we've been able to do is identify survivors directly, a spouse or a person that might have been correlated, or through the investigation we identify survivors. And we are starting to send resources to people immediately, within a few weeks. And we're trying to do it in a non-intrusive way. We want to give people the right to be able to grieve their own way. So it's not a matter of pressure or anything, but we are giving them resources, and if they want more, then we give it to them. But we are giving them some resources right off the bat.
Do you think it would be, would it be feasible to, at some point, sensitivity to time and everything, but given the numbers of potential individuals that would identify as a survivor, would it be possible, do you think it's advisable to try to bring them together in a positive way to actually maybe advocate for mental health first aid in their communities or good behavior game in their school districts? Do you think that something like that is, possible?
I think it is. I think there has to be kind of a community assessment, a readiness assessment sometimes, because for instance, after the Butte suicides, Butte had me in, and I've been continuing to do a lot of stuff in Butte right away. And they were ready. They didn't want to lose any more kids. Some communities, the stigma is much stronger, and so some need to go through a grief process. I think there is a time, but you kind of have to give communities some time to be able to heal and get to a point where they're ready for the services. If you push it on too soon, it doesn't tend to stick.
Yeah, sure, absolutely. Thank you, Carl.
Thank you.
Carl, this is Dan in Bozeman.
Yes.
Carl, is there any better data around coroners and getting accurate information from them? I know in the past it's been an issue that coroners have wanted to protect family members and not necessarily have the death listed as a suicide. Have we gotten any better with that?
Well, yes and no. I still see a lot of that. I still struggle with that when I ask for reports, and there's definitely I'm definitely getting to know which coroners are more thorough than others. I think education is a key piece of it, and if nothing else, the development of the mortality review team has kind of started to spotlight some of these issues, because the good part of it is, if I took a look at a death certificate from 2 years ago, it hardly had any information at all on it. I mean, seriously, name, age, group, race, and where they are from. Now, there's probably 15 to 20 factors that we can pull off a death certificate, because we've completely changed how coroners are looking at some of the deaths, and even how Vital Statistics is recording it. Also, there is an awareness, because I have to submit a report to the governor every year on the findings of our team, and if it comes out, which I anticipate that it will, that one of the barriers is training by coroners, and it becomes a public spotlight, and that's going also to be a area that we can bring change.
Thanks, Carl, and thanks for your great work.
Thank you.
I don't know where we'd be in our state without you.
Thank you.
Carl, we're just a couple minutes over time. If anyone doesn't have any other pressing questions, we appreciate your availability and individuals being able to contact you. If you need Carl's contact directly, my email's in the chat. You can email me as well. And to echo Dan, Ani, Carl, thanks so much for your work and ongoing efforts to keep us thinking about how we can prevent this and suicide among youth and adults in our state.
Don't hesitate to give me a call if I can be a resource to any one of you.
Thank you, Mariola and Joanne.
Great.
We enjoyed the presentation.
Absolutely. Wonderful.
Thank you.